Good morning, and welcome to Grand Rounds. Thank you for joining us. Welcome to the people on the phone and WebEx, and I was asked to just remind everyone to put your pagers and phones on vibrate. I'm Aisha Davis. I'm a hospitalist here and an associate director of our pediatric residency program, and somehow I've held off all of her former program directors and important mentors in order to have the honor of introducing our Grand Round speaker today, Dr. Tiffany Johnson, who's here to talk to us about implicit bias. Dr. Johnson is a pediatric emergency medicine physician at Children's Hospital of Philadelphia and an assistant professor of pediatrics at the University of Pennsylvania Perelman School of Medicine. She's a faculty member in the Policy Lab and in the Center for Perinatal and Pediatric Health Disparities Research at CHOP also. Dr. Johnson is an emerging leader in racial and ethnic disparities in pediatric emergency care and in research on physician implicit racial bias. Her research portfolio really reflects her commitment to improving the quality of care for underserved patients. Her current research is on sources of disparities in the care and outcomes of injured children, and it's supported by the Robert Wood Johnson Harold Amos Medical Faculty Development Program. She's partnering with PCARN, the Pediatric Emergency Care Applied Research Network, and a multi-site investigation of pediatric healthcare disparities. Dr. Johnson graduated from Xavier University of Louisiana, summa cum laude, with honors in biology and chemistry, and then earned her medical degree from Rutgers Robert Wood Johnson Medical School. Many of us know Tiffany here from her time at Children's National. In 2009, she completed her pediatric residency in our own community health track. And as a resident here, she was a star, earning a number of awards, including the Community Health Track Best Pediatric Intern, the Golden Butterfly Award, the Community Health Track Chairman's Award for Outstanding Resident Performance. But perhaps she's best known for her singing in the ED and PICU, which maybe we'll see a little bit of today. After completing her residency here, she spent a year working as a fellow in the Emergency Medical Services for Children's National Resource Center, and then she completed her fellowship in pediatric emergency medicine at the Children's Hospital of Pittsburgh in 2013. During her time there, she was a scholar in the Rand University of Pittsburgh's P32 Research Training Program and earned her master's degree in clinical research with a specialization in health services research. I thank Dr. Odolini and the Department of Medical Education for hosting Dr. Johnson's visit, and I truly hope that the next hour of exploring implicit bias is as transformative for you all as it has been to explore this topic for me. Please help me welcome Dr. Tiffany Johnson.
Good morning, everyone. It's such a pleasure to be back. Let me start off by doing a sound check because I was asked to put on this big black microphone, and I told them that it clashed with my statement necklace. So I just want to make sure that you can all hear me without the giant microphone. I'm getting thumbs up from the back of the room. Well, hello to everyone who's here on main campus, and hello to everyone who's watching on WebEx. It's a pleasure to be here this morning talking to you guys about examining implicit bias in healthcare. So I have no financial disclosures to make, but I will disclose that this is not going to be your typical Grand Rounds presentation. Those of you who know me from training here are probably not surprised about that. And so my objectives for this morning are that upon completion of this Grand Rounds, the audience and those watching at home and in the satellite centers will be able to describe the impact of implicit bias on healthcare disparities and diversity in academic medicine. I also hope that you'll be able to use the implicit association test to critically evaluate your own personal biases. And what I really hope is that after I leave here today, we have several talks set up after Grand Rounds, but when I leave and I'm back home in Philadelphia, that you guys will continue to engage in a dialogue about implicit bias, pediatric disparities, and the importance of workforce diversity. So again, this is not your typical Grand Rounds, and we don't typically have platforms like this to discuss these issues, so I have a lot of information that I'm going to try to get in. I talk really fast, but hopefully you guys will be able to follow along with me. So for my outline, I really want to start off by providing just an overview about healthcare disparities, because that's going to be the unifying thread that's going to link all of these concepts together today. And as we go into our examination of implicit bias, I'll start off by first defining implicit bias and how it's measured, and then I'm going to share with with you some of my research that has looked at the impact of cognitive load on implicit bias and examined bias towards adults versus children. And then next, we're going to link this with how biases are associated with disparities in healthcare. And then we're going to go into some ways that you can reduce implicit bias, including positive black priming, and talk about how implicit bias impacts workforce diversity. And we'll close with just a couple of strategies for how to reduce the impact of implicit biases in both of these areas. So I'm a health services researcher. I tend to not start my talks with a case presentation, but Dr. Ogunlesi gave me very clear instructions that this is how I was supposed to start. And I was an intern on the pulmonary service and a senior on the pulmonary service. So when Dr. O asks me to do something, it gets done. So you guys get a case presentation. So we'll start off with a 13-year-old male who's presenting to the emergency department with 8 out of 10 abdominal pain that he's had for about 12 hours now. He's also been febrile at home with a Tmax of 102, and he's had 3 episodes of non-bloody, non-bilious emesis, no associated diarrhea. And he reports that the pain was worse when riding over with a bump in the car ride on the way over. He did take some Tylenol for the fever and pain and hasn't had any improvement in pain with Tylenol. On exam, his heart rate is elevated to 114. He's now afebrile. He does appear uncomfortable due to pain, but non-toxic appearing. His cardiovascular exam is just notable for some tachycardia, but otherwise a normal cardiac and pulmonary exam. His abdominal exam is notable for tenderness to palpation in his right lower quadrant with rebound and guarding, and he has a normal GU exam. So now when I was a resident here, Devesh was always the first person to try to answer questions, but I want to ask some of my residents and interns here, what's on your differential diagnosis based on this case presentation? Appendicitis, surgical abdomen. So you are suspecting appendicitis, you order some diagnostic testing to confirm that diagnosis. While you're waiting for that testing to come back, what treatment do you want to initiate for this patient? So some people want to do pain meds. Anything else? Antibiotics? Anything else? So when this patient gets in the emergency department, they've had vomiting at home, they get some Zofran for nausea, they get a normal saline bolus because they have some mild to moderate dehydration, and they do get morphine for their abdominal pain. But research shows that whether or not a patient presenting with abdominal pain, even in the setting of an acute appendicitis, one of the factors that determines whether or not they get analgesics depends on whether or not this patient is black or white. And so I conducted a study using data from the National Hospital Ambulatory Medical Care Survey, which is a national probability sampling of ED visits in the country, looking at the association of race and ethnicity with the management of abdominal pain in the emergency department. And what we found was that there are racial differences in analgesia for abdominal pain in EDs nationally. So just to walk you through this figure quickly, here we have adjusted odds ratios where our white non-Hispanic patients are a reference group. For our residents, values that don't cross 1 are considered statistically significant. And here we have our black non-Hispanic patients represented with squares, our Hispanic patients represented with circles, and patients from other races and ethnicities are represented with a triangle. And what we see is that our black patients are significantly less likely to receive analgesics when presenting with abdominal pain with an odds ratio of 0.63. And even when we look at those presenting with severe pain characterized as 7 out of 10 or higher, they were even less likely to receive analgesics with an adjusted odds ratio of 0.48. And then they were also even less likely to receive narcotic analgesics with an odds ratio of 0.37. And some of our colleagues here have done some similar research using data from NAHAMCs looking specifically at appendicitis. So Monica Goyle and some of your other colleagues here found that for those presenting with moderate abdominal pain, they were less likely to receive any analgesics. And among those diagnosed with appendicitis presenting with severe abdominal pain, they were less likely to receive opioid analgesics. And so these 2 articles are examples of a growing body of research showing that racial and ethnic differences exist in the healthcare of children. And in fact, Glenn Flores and the Committee on Pediatric Research conducted a systematic review that identified disparities in a number of areas. So we have a wide range of disciplines represented here in the audience, and I'm pretty sure for every discipline represented, we can identify an article documenting disparities in each of those areas. So they found that disparities exist in mortality, access to care, prevention, population health, health status, adolescent health, chronic disease, quality of care, and organ transplant. And what they concluded based upon this systematic review was that racial and ethnic disparities in children's health and health care are quite extensive, pervasive, and persistent. That's a pretty sad state of the health care of children when you think about it. And so how do we define healthcare disparities? And I like to use the definition from the Institute of Medicine in their report, Unequal Treatment. So what we have here is we see the quality of care, and there are differences between your minority patients depicted in green and your non-minority patients depicted in orange. And these differences are considered disparities if they're independent of clinical appropriateness, access to care need, or patient preference. And disparities are due to injustices within the healthcare system as well as to parts on the part of the healthcare providers. And what they concluded in this report was that bias, stereotyping, prejudice, and clinical uncertainty on the part of the healthcare providers may contribute to racial and ethnic healthcare disparities, and that's what we're going to talk today. We're going to talk a little bit more about bias. So we can define bias as attitudes that are either positive or negative towards a person, group, or idea. And these biases can be characterized as either implicit or explicit. So implicit biases refer to unconscious attitudes, and these attitudes lie below the surface, but nonetheless can also influence your behaviors, in contrast to explicit biases, which are conscious attitudes and therefore can be measured through self-report. And one of the ways that we can measure implicit bias is using the implicit association test. And the way the IAT works is you have to sort pictures and words in 4 different categories. And so this is an example of the race IAT. And so you have to sort pictures and words with the categories black, white, good, or bad. And you have different randomized blocks of trials. So I'm going to walk you through an example of how the IAT works for those of you who haven't taken one before. So in this block, you have to do a categorization of white people are bad, black people are good. So when love comes up, you link it with black people are good. When hurt comes up, it will be associated with white people are bad. When this black face comes up, it will be linked with black people are good. When this white face comes up, it will be linked with white people are bad. And then there will be another block of trials, and again, these blocks are going to be randomized in the order that they appear. But when the black face comes up, this time the associations are black people are bad, white people are good. Black face comes up, you'll link it with black people are bad. White face comes up, you link it with white people are good. Love comes up, white people are good. Hurt, black people are bad. And what the test does is it looks at the number of errors that you make. So if you make the wrong association, you get a big red X in the middle of the screen. But it also looks at your response latency time. So if you're able to do the sorting categorizations more quickly when you have the more stereotypical association of white people good, black people are bad, but it takes you longer to do the counter-stereotypical association of black people good, white people bad, then you have an implicit pro-white, anti-black bias. And the IAT is a tool that's been used for, over 15 years now in hundreds of studies across a range of disciplines. And what we know from this research using the implicit association test is that it's a validated tool that has good psychometric properties. We also know that the IAT is resistant to deliberate faking and that it's more valid than self-report. And research using the IAT shows that most Americans have an implicit pro-white, anti-black bias. And then over the years, there are now about 30 articles that have been using the IAT among healthcare providers. And similarly, we find that healthcare providers, similar to the general population, most healthcare providers have an implicit pro-white, anti-black bias. So why does this matter? Why do we care about what people's unconscious attitudes are? And the reason this is important is because research shows that implicit biases predict behavior. So for example, in a study among college students, they found that when interacting with a white experimenter versus a black experimenter, white undergraduate students who had more pro-white bias on the IAT had longer speaking time, more smiling, more social comments, fewer speech errors, and fewer speech hesitations. So when you think about some of these nonverbal communication skills that kind of come into play based on your implicit biases, I want you to reflect on how that may come into play when you're interacting with your patients. And so I'm an emergency department doctor, and so I was interested in understanding how factors in our work environment might impact our implicit biases. And one of the reasons I was interested in this, because life in the ED, similar to other acute care settings, is a little bit chaotic. So we have to face high patient acuity, we have time pressures, we have to multitask. Oftentimes we have workflow interruptions where I'm getting a call from transport while I'm trying to put in orders for a patient. Just due to the nature of emergency department work, there tend to be lots of handoffs associated with care, and we have high patient loads. And so we find ourselves making multiple time-sensitive decisions about multiple patients in the absence of a doctor-patient relationship. So for every patient that comes through, I'm wondering, do I need to order diagnostic tests? Should I call a consultant? Should I admit them? Should I discharge them? Are they going to follow up? And then me personally, I also am usually asking myself at the end of the shift, why is my bladder above my umbilicus? Did I eat? Did I pee? Did I have anything to drink today? So we have to make multiple decisions, and we face multiple cognitive stressors. You guys are laughing because you've done that too. Yeah. And so research in social psychology shows this concept of decision fatigue. So the more I think, the more confused I get. So it shows that the more decisions that are made, then the more difficult each subsequent choice becomes. And in the setting of this decision fatigue, the brain then begins to use heuristics, which are mental shortcuts. And heuristics can include bias and stereotyping. So those of us, I have lots of my ED homies in the front of the audience. So those of us who work in the emergency department, we know this. Like in the beginning of the shift, when neurology calls you and they want the $1 million workup for the patient that's been done 4 times already, you tend to give them a lot of pushback about what really needs to be done. But at the end of your shift, you're like, whatever neurology, whatever test you want so that I can get this patient admitted, and we kind of default to some of these heuristics. And one example of this decision fatigue is illustrated in this study about Israeli parole judges. So what we see is that when you go, in Israel, if you go up for parole first thing in the morning, your odds of getting parole, you have about 60% chance of getting parole, and then the rates of parole go down to nearly 0 until right here. Anybody have any thoughts about what might happen right here? Well, they actually get a breakfast break in the Israeli parole. So they give them I don't eat till the end of my shift, but they get a breakfast break. So they get breakfast, and then the rates go up to, again, about 60%, and then come down to nearly 0. This is when they have lunch. Rates go up to about 60%, come down to nearly 0. And so I actually have put this into play. I had to get surgery a couple of years ago, and the surgeon said, well, you know what, I'm happy to, add you on as a case. I said, oh, no end of the day cases. I want to be first thing in the morning when you don't have any decision fatigue, and the surgery went really well. But so just think about how this may come into place for us emergency department doctors with what's happening to us at the beginning of our shift versus the end of our shift. So this is what I was interested in. So my hypothesis was that resident physicians face multiple cognitive stressors during an ED shift that will result in higher levels of implicit bias at the end of their shift compared to the beginning of their shift. And so to test this hypothesis, I performed a repeated measure study of resident physicians in the ED between April and June of 2013, and we administered internet-based surveys before their shift and at the end of their shift that included demographic information. We asked them to self-report some of their workday characteristics, and we also had measures of explicit and implicit racial bias. And so we actually were able to enroll 91 out of 103 residents who are working in the emergency department during our enrollment period. We can talk a little bit later about some of my incentives for how we got such a high response rate. And of those 91 participants, 74% were white non-Hispanic, represented here in red, 1% were black non-Hispanic, 4% Hispanic, 13% Asian, and 8% from other races and ethnicities. Of our participants, about 52% were female. And we had a pretty good range of specialties in the emergency department, so about 45% of the trainees were pediatric residents, while 35% were from emergency medicine residency programs, and 19% from other programs, which included family medicine, anesthesiology, psychology, who rotates through our emergency department. And here we have the results of their self-reported explicit racial attitudes. So we asked participants to report through 2 different questions their feelings towards white people, which are depicted in red, and their feelings towards black people, which are predicted in blue. And we gave them a temperature scale from 0 to 10, where 0 represented cold feelings, 5 represented neutral feelings, and 10 represented warm feelings. And what we found was that none of our participants had cold feelings towards whites, but 4% explicitly reported having cold feelings towards blacks. About a third had neutral feelings towards blacks and whites, and most had warm feelings, with 68% having warm feelings towards whites and 60% warm feelings towards blacks. And then in our last explicit question, we asked them to what their preference was for blacks or whites on a scale from 0 to 10. There's a little bit of bias in how the question is worded, but 0 is prefer blacks, 5 was neutral, and 10 was prefer whites. And what we found was that 2% of participants explicitly preferred blacks, while 68% had no preference, but 29% did report that they explicitly preferred whites over blacks. Next, I'll walk you through our results of the implicit association test. So the IAT is a continuous measure that ranges from -2 to +2, where negative values indicate a pro-black bias, positive values indicate a pro-white bias, and there's standard cutoffs for categories of bias that range from no bias, slight, moderate, to strong. And as you can see here, most of our participants had a pro-white bias both before and after their shift, with a mean IAT score pre-shift of 0.50, which falls into the category of moderate pro-white bias. And then at the end of the shift, depicted in blue, the mean IAT score was 0.55, again falling into the range of moderate pro-white bias. So when we looked at our sample overall, there weren't any significant differences pre to post-shift, but again, we also asked residents some self-reported factors about their workday, and we looked at analysis of what factors, which of these cognitive stressors were associated with end-of-shift bias. And the things that played out where we found that there was a significant association between patient load and between emergency department overcrowding. So we looked among participants who took care of more than 10 patients, and what we found that in that group who had a higher load, their mean IAT score before shift was 0.46. After the shift was 0.63, with a change in IAT score of 0.17 that was statistically significant with a p-value of 0.06. We also calculated a Cohen's d, which is a measure of effect size, because these IAT scores can be a little bit difficult to interpret. So your IAT increases by 0.17. What does that mean? Is that clinically significant? And so Cohen's d is a measure of effect size, so we consider anything greater than 0.2 to have some effect. So we do see that caring for more than 10 patients did have some effect on the change in IAT scores. The other factor that we found to be associated with post-shift and change in IAT scores was ED overcrowding, and this was an objective measure of overcrowding based on the number of patients in the emergency department relative to the number of admissions and the number of beds in the hospital. And what we found was that when the emergency department was more overcrowded, the pre-shift IAT scores was 0.48. Post-shift was 0.57, with an increase in IAT scores of 0.09 that was statistically significant with a p-value of 0.03. And again, our Cohen's d indicated that ED overcrowding did have an effect on change in IAT scores. So, but we're pediatricians, right? So this IAT used the adult race IAT, which shows pictures of adult faces, so that may show us our attitudes towards parents. But what about our attitudes towards children? So I hypothesized that resident physicians would have less bias on a child race IAT, which was actually developed to determine when children develop their implicit racial biases, so it was developed to give to children, but I wanted to give this to providers in the emergency department. And I thought that we would have less bias on child race compared to the adult race IAT. And I also refer to this as my everyone loves brown babies hypothesis. Like, they're super cute, they have cute little afros, everybody loves brown babies, there's not going to be any bias on this IAT. And then, no, I wanted to make that the title of my paper, and my co-authors vetoed that title. And then my second hypothesis was that adult and child race IAT scores will be lower among pediatric residents. Maybe that's a little bit of my bias, but pediatricians are warm and fuzzy. Like, we give hugs instead of handshakes, and I just thought that we would have less bias on the IAT. So to test this hypothesis, we measure implicit racial bias using the adult race IAT that I previously described for you, and the child race IAT, which uses the exact same procedures, but instead of pictures of those kind of scary white and black adult faces, they had pictures of these super cute black kids and these super cute white kids with pigtails and smiley faces. And so here we have the results of the adult race IAT are depicted in red, and the child race IAT depicted in blue. And what we see is that overall residents had pro-white bias on the adult and child race IAT. For the adult race, the mean IAT score was 0.49. Again, that falls in that moderate pro-white bias range. For the child race, the mean IEP score was 0.55, again, falling in the range of moderate pro-white bias, and these values were not significantly different from each other. So even though I hypothesized everybody loves brown babies, what we in fact found was that resident physicians have similar levels of implicit bias against Black children as they do against Black adults. I also hypothesized that the pediatric residents were going to do better on both IEPs, but we actually found that bias in our study did not vary by any resident demographic characteristics, so it didn't vary by age, by PGY level, by gender, or by specialty. And so what this indicates is that pediatric residents are equally as susceptible as other physicians to implicit bias, even towards those cute little brown babies that are coming into the emergency department. And so, again, why is this important? So we have these unconscious attitudes, but, like, who really cares? And the reason why this is important is because there's a growing body of research showing that implicit bias is associated with disparities. So, for example, higher implicit bias on the using the implicit association test has been linked with racial differences in chest pain treatment using clinical vignettes. Even in pediatric populations, it's been linked with racial differences in prescribing narcotic analgesics for pediatric postoperative pain. Again, this was a study using clinical vignettes. And then in terms of actual patient care, research has shown that providers that have higher IEP scores have poorer communication with their Black patients during their visits, and also poorer ratings of care from their Black patients during the visits. And then one study has also shown that higher IEP scores is associated with poorer psychosocial health outcomes for patients with spinal cord injuries. So again, these may be unconscious attitudes, but there's a growing body of evidence that show that even our unconscious attitudes actually are associated with disparities in care. And there's some new evidence that shows that implicit biases are actually malleable and can change over time. So in a recently published study in the Journal of General Internal Medicine, they actually looked at how medical school experiences are associated with changes in biases. And so this study was conducted among 3,500 medical students from 49 different medical schools across the country. And what they found was that factors associated with increased bias, so they gave the IEP to first-year students and fourth-year students. Factors associated with increased bias at the end of your medical school training included the hidden curriculum. And so I don't have time to get into this during grand rounds, but we're actually going to talk a little bit more about the silent curriculum during noon conference today. So I would encourage you guys to stop by so we can have some more discussions about this silent curriculum, which has been found to increase medical students' bias. And they also found that increased bias at the end of training was associated with negative comments from faculty members. And I think this is a really important point because as faculty members, we, frequently will make comments, I'm a joking kind of person, but I want you guys to know that your words have an impact on the trainees who you are working with. So I want you to think twice before you make a negative comment about the drug-seeking patient that's in your emergency department, or about the patient who you think is accessing the ED inappropriately, or about, someone's language barriers or the clothes that they're wearing, because the comments that you make impact your trainees and are actually associated with increasing their unconscious racial attitudes. So on the bright side, what factors are associated with decreased bias? So they found that factors associated with decreased IEP scores was just completing an IEP as a part of their medical training. Another factor was if medical students had self-reported self-efficacy regarding the care of Black patients. And then the last one is my favorite one. Favorable contact with Black faculty members reduces implicit bias. And this, is a lot to me because I'm a Black faculty member. So I like to call this the tip effect. I'm trademarking it. So favorable contact with Black faculty actually can reduce implicit bias. So I'm such a believer in this that I actually change my glasses and my hair on a regular basis so that every time trainees come in contact with me, they think I'm a different person to really amplify the effects of this. So this is unpublished data. But I'm a big believer in the tip effect. And actually, even though this is unpublished data, we did see some trends in my actual research that looked at this. So when I gave an implicit association test before shifts, I was one of the recruiters in that study. We also had 2 white female recruiters, 2 white male recruiters, and 1 Asian female recruiter. And I wanted to test out this tip effect, what does just being in my presence, how does that impact your bias? And so what we found was that before the shift, if I recruited them, their mean IEP score was 0.43. If it wasn't TIFF, Their mean IHP score was 0.57. So I really think like I can like bottle myself up, like I have something going here with, you know, the tip effect and reducing bias. And so there's actually other research that, you know, for those of you who still are not believers, who may not have had the chance to work with me, and you're not a believer in the tip effect, maybe you'll believe in the Denzel effect. So there's other research showing that you can actually decrease implicit bias through positive black priming. So in this study, what we have here in the white bars are your stereotypical associations, so your white pleasant, black unpleasant, and in the black bars, your counter stereotypical association, black pleasant, white unpleasant, and you have your response latency time here. So what we found is that if participants had no racial prime, that it was easier to associate white with goodness and black with badness. It took them longer to do the counter stereotypical association. And then next, they gave them a pro-white exemplar. This study was done in the 90s, so Tom Hanks was one of the examples of a pro-white exemplar. So they kind of positively primed it with Tom Hanks, then gave the IAT, and we have similar results as if there was no racial prime. The next, they primed them with Denzel, right? So flash some pictures of like Denzel, MLK. I'm gonna do this with like pictures of me with different hairstyles. But so when they got positively black primed, what we see is that they were actually able to more quickly do the counter stereotypical association, and it was less challenging for them to associate black with pleasant when they got primed with Denzel. And so what they concluded from this was that exposure to admire black exemplars can actually weaken your implicit bias. And the IOM believes in this too, and so the IOM in their report on unequal treatment, they recommended increasing the proportion of those who are underrepresented U.S. racial and ethnic minorities among health professions as one strategy for reducing healthcare disparities. So we talk about these groups of URMs, and so just a quick definition of URMs. URMs can be defined as racial and ethnic minority groups that are underrepresented in the medical profession relative to the general population, and this currently includes African Americans, Hispanics, Native Americans, Alaskan Natives, and Pacific Islanders. And so, you know, the IOM recommends this, Denzel recommends this, I recommend this, but there's actually some other research that shows that there are some benefits to having diversity in academic medicine. So, for example, we know that diversity is good for our patients. So literature shows that URMs are more likely to practice in underserved areas, so it's important to train this group of this population. And we also know that minority patients are actually more likely to adhere to their treatment recommendations when there's racial concordance between the patient and their provider. And not only is diversity good for our patients, but diversity is good for academic medicine. So research has shown that increasing diversity helps to enhance the educational experience for all. Anybody from class of 2009 who trained with me in the audience here today? None of them are here, but they can attest to the fact that having diversity in their training program enhanced the educational experience for all. And research also shows that when you increase diversity, it helps to broaden the breadth and depth of research, and it also just makes good business sense. So when patients are more compliant, more likely to follow through, then it makes good business sense for your health outcomes. Yet, despite these known benefits of increasing diversity in academic medicine, I think the best way that we can describe it right now, the state of diversity, is that it's a leaky pipeline. So we know that these groups that are considered underrepresented in medicine make up about 30% of the U.S. census. However, when you look at medical schools nationally, only about 12% of medical students come from groups that are considered underrepresented in medicine. I bet you guys wonder where GW comes in, huh? You guys are pretty close. So GW has about 11% URMs in the medical school. And when you look at pediatric residency programs nationally, about 15% of pediatric residents come from groups that are underrepresented in medicine. Where do you guys think you line up? Higher, lower, the same? Higher. Some people think higher. Some people think the same. Lower. So right now, about 9% of the residents in your training program come from groups that are considered underrepresented in medicine. And then we see some of the real leaks in a pipeline when you go from transitioning from training programs to actual academic medicine faculty positions. So when you look at the assistant professor level, only 7% of assistant professors in pediatrics nationally come from URM groups, 5% at the associate professor level, and 4% at the full professor level. I don't have your numbers here, but I would encourage our leaders who are in the audience to think about where do you think you line up and where are you at trying to decrease some of the leaks in your pipeline and increase the number of underrepresented minorities who are in faculty positions here at Children's National. And so why do some of these leaks exist in a pipeline? And one of the reasons is because of the negative experience that URMs experience in academic medicine. So URMs have cited feelings of isolation and feeling invisible, a lack of mentoring, role models, and social capital, different performance expectations related to their race where they feel like they have to perform twice as hard to be seen as equally as good, a devaluing of community health and disparities research, and an unfair burden of, on one hand, being identified with affirmative action. So people think that you don't deserve the position that you have and you only got there because of affirmative action. And at the same time, feeling a responsibility to be involved in diversity efforts, where if you're one of the only minorities in your division or department, you get asked to be on every committee that needs a diversity representative, and you're spending there's laughs from people over there who have had that asked of them. But when you're spending all your time sitting on committees, then you don't have time to actually perform the job that you're getting rated on for your promotion, and this causes some leaks in the pipeline. And so we can sum this all up as the black tax or the brown tax. Anybody ever heard of the black tax in here? I only see brown hands going up. All the brown faces in here know about this brown tax. And so when we think about the brown tax, we see that everybody who's in academic medicine has certain research, teaching, and service responsibilities. That proportion is going to vary depending on what track you are in academic medicine. But on top of that, URM faculty face an additional burden that really makes it challenging to survive and thrive in academic medicine. And URM faculty have also reported experiencing both implicit and explicit bias and discrimination, and these are all factors that may result in leaks in this academic pipeline. So even though URM faculties report experiencing this implicit and explicit bias, there's actually a growing body of research to document that it actually is in fact taking place. So in this study, looking at implicit bias in academia, they sent off correspondence to over 6,500 professors in 259 institutions across 89 different disciplines. And they sent off correspondence from fictional prospective students contacting them saying, hey, I'm thinking about coming to your university. Can we set up a meeting to talk about research? And they randomly manipulated the names to signal different genders and race, but the message was otherwise identical. And what they found was that faculty were more responsive when they received a correspondence from a white male compared to females as well as underrepresented minorities. This was, the gap was greatest in business, but depicted here in red, you see that there was also a discrimination gap in the health sciences. And even in the NIH, they're now starting to look at implicit bias in grant funding. So research has shown that if you are white, you get funded about you're twice as likely to get funded as blacks in NIH funding. And now they're starting to look into how implicit bias may be playing a role in the discrimination gap in NIH funding. So I was interested in knowing, so we know that most Americans have implicit bias. We know that a lot of physicians have implicit bias, but most of that research has been across a spectrum of people, including trainees, residents, and medical students. But what about the people who really matter? Like, what about those people in leadership positions who are leaders in recruitment roles? So I administered an implicit association test. This was done both at CHOP with our division chiefs, department chairs, residency program directors, and fellowship program directors. And I also administered it to a group of participants in a national workshop at the Pediatric Academic Societies meeting, and it was a workshop on recruiting and retaining minorities in academic medicine. And I gave a paper version of the implicit association test. So it has, it's very similar to the electronic IET. We have categories of black, white, pleasant, and unpleasant, but instead of black and white faces, we use names that are stereotypically black, like Malik or Tanisha, or names that were more stereotypically white, like Melanie and Brandon. And what we found was that overall, about 28% of our participants had no bias, but most of our participants, 60% of those who are faculty leaders and in recruitment roles, have an implicit pro-white bias. So again, what are the implications of this when those who are in leadership positions making decisions about who gets promoted, who gets other leadership positions, and those who are in recruitment roles making decisions about who gets selected for residency, who gets selected for fellowship, and who gets selected as a faculty member? How do these implicit racial biases come into play with these decisions and impact some of the challenges to diversity in academic medicine? So I painted a little bit of a bleak picture here. So I want to give you guys some encouragement. And I'm going to use the Ohio State Cardiology Fellowship Program as an example. So at Ohio State, in their fellowship program, between 1955 and 2007, for 50 years, they did not have one single URM in their fellowship training program. And somehow it took them 50 years to realize this was a problem. I suspect the ACGME may have pointed it out to them, but I cannot confirm that. But after 50 years, they realized this was a problem and got some motivation to do something about it. So what did they do about it? So they decided to make diversity a top 3 priority for their match list. So I want those of you who are on intern selection committees and fellowship selection committees, think about what either the implicit or explicit priorities are for your match list. It's probably board scores and where you trained. I'm pretty sure diversity doesn't fall into that top 3. But they made diversity a top 3 priority. They also reached out to diverse training programs. So I'm at CHOP. I'm in an ivory tower just like you guys. And I think people in ivory towers, but like, you don't need to recruit people. You want people to come to you, offer to give their left kidney to have the opportunity to train in your program because it's so wonderful and so phenomenal. But they realized that if they wanted to have a highly qualified pool of minority candidates, they had to go out and actually recruit them. So they reached out to diverse residency programs, and then they also altered their interview day, because when you have URMs coming through interviewing and they see nobody that looks like them, that's a signal that this is not a place where I'm going to be successful. And they didn't have any in their division, so they had to go to other divisions and departments so that minorities had an opportunity to interact with other minorities to show them that, yes, you can come to Ohio State, and yes, you can be successful here. And as a result, they were able to go from 0 for 50 years and increase their number of URM fellows to between 20 and 25%. So diversity in academic medicine actually can be done. So at CHOP, we actually have a couple of strategies in place. We have both a Multicultural Physicians Alliance, which is just at CHOP, that has activities related to recruiting URMs into the residency training programs, but also once we get them there, activities in place to help retain them and make them feel welcome and help them to survive and thrive at CHOP. And then also we recently started a program called the Alliance of Minority Physicians, recognizing that there may be few minorities within any individual division or department, but across Penn's campus, when you bring everybody together, there are hundreds of us. So the Alliance of Minority Physicians, again, targets recruitment, but also professional development and retention to help create a community of support for minorities in academic medicine at the University of Pennsylvania. All right, so I want to leave you guys with just a couple of strategies, because I've told you all that you probably have some racial bias. If you haven't done the IET, I would encourage you to do it. But like most Americans, there's a lot of racial bias. But what can we do about it? So I want to leave you with a couple of strategies for how we may potentially reduce the impact of implicit racial bias. And of course, my number 1 strategy is the tip effect, right? So my number 1 thing I'm going to leave you with is positive black priming to counter automated stereotyping. And so one of the best ways that you can positively prime your faculty members and your trainees is by increasing diversity here within your training programs and within your faculty members, so that people get exposed to positive African Americans that can counter some of the stereotypes that they have about African Americans. Another suggestion is system-level interventions aimed at reducing some of the cognitive load. So even if you can't necessarily decrease people's implicit bias, how can you impact the work environment to reduce some of the effects on bias? So what do we need to do to change our staffing models so that the ED isn't overcrowded and so that residents don't have a high patient load, so that we can reduce some of these impacts of bias, so that we don't revert to bias and stereotyping when making our clinical decisions? Another thing to think about is quality improvement initiatives. So when we think about medical errors in the hospital, we think about not just fixing the person, but how do we fix the system? So some of this human factor science. So how do we develop clinical effective guidelines so that we can reduce the overall variability in care, and that can help to reduce the racial and ethnic variability in care? And then I would also leave you with suggesting that there's some implicit bias training for academic leaders and those who are involved in recruitment, so that we can reevaluate who gets residency positions, who gets faculty positions, and who gets promoted. So we covered a lot of ground. I'm out of breath. So we talked about a lot of things today. So just in summary, today I gave you, I kind of laid the framework by providing you with an overview of healthcare disparities, and we kind of delved in and touched a little bit on examining implicit racial bias in healthcare. We defined implicit bias. We discussed how it's measured using the implicit association test. I discussed my research looking at the impact of cognitive load on bias, and informed you that unfortunately everybody doesn't love brown babies, and that providers have equal levels of bias towards children as they do towards adults. And we looked at the impact of implicit bias on disparities, which I think is one of the most important things. So our attitudes actually affect patient care. We talked about the tip effect and reducing bias through Black priming. And we talked about how this kind of all ties together with workforce diversity and how there's both implicit bias and workforce diversity, and how we may need to increase diversity as another strategy for addressing pediatric disparities. And I want to leave you guys with one challenge. So I know that a link was sent out to you guys when the announcement went out for grand rounds, and I would encourage all of you guys who haven't done so to log into Project Implicit. I'm not affiliated with them. I don't get like $1 for every IAT that's taken, but I would encourage you to log in to take an implicit association test. There's the race implicit association test, but you can also explore some of the other biases that you have. So they have tests related to gender bias and bias against obesity. And so just kind of start exploring what some of your biases are. And because I think if you're more aware about your biases, you're better equipped to check them at the door before you walk into your patient encounters. I would also encourage you guys, again, I'm here giving grand rounds for an hour, and I'm around throughout the day to kind of delve a little bit deeper into some of these topics, but I'm leaving at the end of the day, and I hope that when I leave that you guys will continue to engage in a dialogue about implicit bias and about pediatric disparities and workforce diversity. And now this is like my Oscar moment, so I'm going to give a couple of shout-outs before I open up for questions. So I first want to acknowledge my funders. So I was funded by T32, followed by K-12, and now I'm funded by the Robert Wood Johnson Harold Amos Medical Faculty Development Program. Without them, I certainly would not be here. And my University of Pittsburgh co-investigators, where my work on cognitive load and brown babies was done. And then I also want to acknowledge my CHOP mentors and co-investigators who helped me to do my current body of research. But most importantly, I have to give shout-outs because I trained here. So I want to thank Dr. Aisha Davis. I think Mary Olini had to step out, but thank you guys for inviting me back to come to Children's National and talk to you about these issues that I'm really passionate about. And then I also have to give a shout-out to Joe Wright, who's in the audience today. And so Joe was here when I was a resident, and he is who I consider like my father in academic medicine, so he's like more than a mentor, more than a role model, and really played a large role in me going into academic medicine. So I came into Children's National in the community health track wanting to serve underrepresented populations with no desire to do research, and he was a good role model for how you can do those things that you're passionate about and do it in academic medicine and be successful. So shout out to Joe Wright. And then I'll also shout out Dr. Cora Bramble, because when I was here, I'm hoping that some people have come through your pipeline since I was here. But when I was here from 06 to 09, Joe Wright and Denise Cora Bramble were the only two URM full professors at the time. So still the case, all right. So no one else has come through that pipeline. But again, a shout out to them, because URMs need to see successful leaders who are able to be successful in academic medicine. So I would encourage you guys to keep getting some more people through that pipeline. And then shout out to the community health track, who I already heard earlier. I was a community health track member. And then to all of my colleagues in the Division of Emergency Medicine, this is where my clinical passion was ignited here at Children's National. So thank you guys for showing up early in the morning when you were probably working last night and supporting me. And then I also just want to acknowledge the nobody's here today, but I have to shout out the Children's National MOCA MD. This is like an official group, class of 2009. And I put this up there to leave you. So in my intern class, there were 7 Black females. Have you guys seen that since then? I'm pretty sure you haven't. So there were 7 Black females, and 5 of us were really close. Actually, Marseille's group started the MOCA MDs, and so I was the next generation of MOCA MDs in 2009, and we really created a community of support. And this group was, they helped me to survive and thrive in residency. And I also put this up there to show you, like, we were all pretty dope, like we've gone on to do some pretty amazing things. So I think that there's this paradigm that in order to increase diversity, you have to lower the bar, but my MOCA MDs have gone on to do wonderful and phenomenal things. So I just want to shatter that paradigm that you do not have to lower the standards in order to increase diversity. And now I'll open it up to questions.
Question would be, how about the Obama effect? So have you looked at any data after Obama has become president?
So all of this data was collected after Obama was president. And so for those of you who think that we live in a post-racial society and now that we have a Black president, bias does not exist, that is not true. So all of the data that I presented from my research was conducted 2013 and beyond. after Obama was president. But actually, Project Implicit is doing some research to look kind of at pre and post. But the IEP scores that I have found are consistent with research that was done 10 years ago. So unfortunately, I don't think Obama has positively Black primed as much as we would have liked them to. But
excellent talk. Oh, I guess I can just yell. Can you speak to? Oh, it is? Okay, sorry.
Hi.
In our ER, 25% of our patients at least are Spanish speaking.
Mm-hmm.
Can you talk a little bit about the biases, Latino community, and that in addition to ethnicity, language barrier? Because I think that's going to be one of our biggest challenges in pediatrics as we see an increase in Spanish-speaking patients.
Did everybody hear that question? So this is a question about the fact that here at Children's National, we serve a large Latino and Spanish-speaking population. So I spoke today mostly about pro-white and anti-Black biases, but what about this whole other group of patients? So there actually are some ethnicity-based IEPs, and some of the research looking at physician communication has shown that pro-white, anti-Latino bias is associated with physician communication, but they actually didn't find that same association with patient ratings of care as they did with the pro-Black bias to the anti-Black bias compared to the anti-Latino bias. But I think that this is a very important area of research. And so in my initial study where I was in the University of Pittsburgh, less than 1% of their population was Latino, so I didn't include a Latino implicit association test. But in my work that I'm doing at the Children's Hospital of Philadelphia and in the work that I'm doing with the Pediatric Emergency Care Applied Research Network, we are including an ethnicity implicit association test, one with both faces as well as with names, because especially in the ED, a lot of times you don't see the patient before you decide who you're signing up for, but you see Rodriguez on the board. And so are there some disparities with who we wait to see longer because we see Rodriguez and don't want to be bothered with an interpreter? So I'm going to be doing some research in this, and there's a growing body of research, but again, showing that there are similar anti-Latino biases as they are anti-Black biases, but because this body of research is just growing, still not as much evidence showing how that bias impacts care.
Tiffany, we're so proud of you. It's really a pleasure.
I told Denise when I came in, because she was like my work mom, so I'm like, I'm all grown up. Look at me now.
I do have a question. Here at Children's, it is true that on the clinical side, there are 2 to full professors, Joe and I. On the research side, I do believe there are maybe 1 or 2 more. This is an area of interest for me to see how we can groom those that are assistant professors, and I've sort of taken that as sort of a personal mission. The question I have for you is, what recommendation or suggestion do you have for Children's National as a whole in terms of supporting those junior faculty members and moving them along in terms of, training them, capacity building, and whatever we need to do to move those junior faculty members onto the next level? I do think there's a huge gap, and we have work to do.
Absolutely. So I am actually meeting with, I think you're going to be in this meeting at 9 o'clock, and a couple of other people to talk about some of these challenges with recruitment and retention. So I think some of the strategies for how you retain people and keep them on a pipeline, number 1, make people aware of what their expectations are. Because if you don't know what your expectations are related to tenure and promotion, you're not going to be able to survive in academic medicine. So I think that that's one place. And mentorship, I think, is also incredibly important. So the only reason why, I'm very junior in academic medicine, but I've been very fortunate to have amazing mentors to help me out along the way. And I think it's important to have formalized mentoring programs for minority faculty members in all tracks to help make sure that they are successful. And those mentoring relationships can really help you identify problems early on, because I think a lot of times we realize that people aren't happy when they come into your office saying that they're resigning or they're leaving and going somewhere else. So developing some formalized mentoring relationships to help people early in the process to identify what the challenges are before they're ready to walk out the door are really important. And, I also think that we need to reevaluate the promotion process and what institutions value, because if what your URM faculty are passionate about, things that they're doing working in the community, or if those things are not aligned with what you can get promoted for, then they may want to drop out of academic medicine. So how do we reevaluate what our promotion processes are so that we can make a space for people with diverse interest to be able to be successful. And there's some models of that where, 10 or 15 years ago, people who were more like your clinician at on your teaching tracks, there wasn't really a model for how to promote them in academic medicine, and there are new metrics for how to count teaching so that you can get promoted. So how can we develop new metrics so that people who have more community-related interests can get promoted as well? And I also think addressing implicit biases that faculty members experience, and then protecting your URN faculty members. So that's one thing that's really helpful for me is I have mentors who serve on my NO committee, so that when I get asked to serve on every diversity initiative, they're like, no, Tiffany, you can't do that because guess what? You're supposed to be writing papers and you're supposed to be writing grants. So, giving them protection so that they can really work on the things that are going to make them successful.
I just wanted to thank you. This was not only a very entertaining presentation, but the issues you're dealing are so important. And you probably remember that this is not usually the normal size of the grand rounds. I think that the number of people the standing room only represents not only the TIF effect, but also how seriously we recognize that this is a problem. We're actually going to be starting under Mike Byers, who I think is in the audience here, in HR, a whole process to look at implicit bias and what we can do about it. I had one question for you, which is when you give individuals of colors the implicit bias, my recollection in reading is that they also have a bias, and that their bias also is towards non-people who are white. And I wondered if you could speak, whether, am I remembering this correctly, and if I am, can you speak to what you think is going on there and how we deal with that if that's also an issue?
So there have been literally hundreds of studies looking at implicit bias in America. When looking specifically at healthcare providers and minority healthcare providers, most of the studies have shown that Black healthcare providers, most of them have either no bias or a slight pro-white bias. But even in looking at that group that has no bias, there's a large standard deviation. And what that indicates is that you have some people with no bias, but you have some with a pro-Black bias, you have some with a pro-white bias. And when you put us all in one bowl and calculate our mean, the mean is no bias for most studies, and then some have shown a slight pro-white bias. And when you look at Latinos, most Latinos have a pro-white, anti-Black bias. And I think the reason for that is because Blacks and Latinos live in the same America that whites live in. So they sometimes get exposed to the same negative images of minorities in the media. They get exposed to the same hidden curriculum in the work environment that can impact their biases as well. So being a minority does not make you immune to bias, but again, at least in healthcare providers, most research has shown an average of no bias, actually.
Tiffany, one of the challenges of, oh, sorry.
Okay, just quickly, I just want to echo what everybody has said, and as you all saw, she started by saying when Dr. O asked for something, she does it. She did, but she didn't listen to me. She didn't come to pulmonary. Devesh won by his fast talking, so he gave her the fast talking skills, and Dr. Korobambo won with her expression. All right? Thank you so much, Tiffany.
Thank you for having me.
But this audience is very diverse. I know you've touched on many aspects that relate to providers, especially, but we have many nurses. We have lots of people from HR. We have, a very diverse group here, and many who are listening online because they read Dr. O's email and they all tuned in. And how would you encourage an environment where Mark and Steve and several other leaders now at Children's that I have seen in the 12 years I've been here are encouraging a lot of the diversity issues? Aisha is championing the cause for the residency program supported by our able residents who are still here and who are going to stay, whether they like it or not, Marseille and the rest of us. How would you encourage the person who is in environmental services, the new nurse who is on 7 East, who feels like as a URM, underrepresented minority, in their small caucus, in their little department, can affect or effect change in an institution like this?
So thanks for that question, Dr. O. So I think everybody that is working at Children's National, you all have contact with patients and all kind of have an impact on what the environment is here. But I will also still say, there's a challenge to the leadership to recognize that you treat everyone with respect. So when I started residency, my mom warned me, like, Tiffany, you better be nice to those nurses because they can either, like, make you or break you. Like, if you're mean to those nurses, they're going to call you and page you all night. So, I had good home training that made me nice to the nurses. But all of you guys weren't taught that by your parents. So let me say it here that, we are all in this mission together. I cannot do my job and you cannot do your job without environmental services. And, physicians can't do their job without nurses. So, making sure that we respect all of those who are involved and talk to them with respect. And some of those things are related to that hidden curriculum. But also for those people who are in those positions, doing your job as best as you can and speaking up when injustice is taking place. So I know I'll say that to the trainees as well. I kind of had, a change where I was actually really quiet at one point in my life. I know that you guys may not believe that, but I was really quiet at one point in my life, and somehow, I kind of found a voice and recognized that, your evaluations or your grades are less important than speaking up for vulnerable populations. And so our environmental services and our nursing and, HR, they also have a role in helping to make sure that when people are making negative comments that you speak up to, speak truth for those vulnerable populations as well.
Tiffany, one of the challenges of health services research is that we have a lot of information about process measures, but we have very little about outcomes and nothing about patient preferences. Are you doing any research, or are you aware of others that are looking at outcome measures such as reduction in pain score or patient preferences for opioids versus non-opioids, for example?
You're like a plant audience. So as a part of my career development award, so I kind of am approaching my disparities research in 3 different phases, where phase 1 is identifying disparities, starting there because pediatricians think we're warm and fuzzy and disparities don't exist in pediatric patients, so documenting what some of the problems are so that we know what problems need to be addressed. But I'm currently in that phase 2 disparities research, where I'm trying to understand the sources of those disparities. So that body of research is including looking at implicit provider bias and how bias impacts disparities, but I'm also looking at parent and system level factors that contribute to disparities. And actually, in looking at the literature, there weren't any any existing instruments looking at preferences around care. And so when you look at that report, Unequal Treatment, which had hundreds of studies on disparities in adult populations, they concluded that patient preference did not have a significant influence on disparities, but yet in peds emergency medicine, at least, there's this dialogue that preferences are contributing to disparities. So I've developed an instrument looking at requests and refusals that every day I'm like, any day now we'll start enrolling to really look and see how different preferences vary by race and ethnicity and contribute to racial and ethnic differences in care. And we are looking at more patient-centric outcomes, including not just administration of analgesics, but reduction in pain scores as well. So invite me back in a few years and I'll talk to you about that.